If anyone is on Facebook, just let us know if you're able to see this. Okay, so it looks like we are live on Facebook. So good morning. Oh, I should record this as well. And recording to, all right, perfect. So good morning, good afternoon, good evening. I would like to take this opportunity to welcome everyone. I am Dr. Akwi Asambang. I am an interventional gastroenterologist. I am the co-founder and board president of the Pan-African Organization for Health, Education, and Research. And I'm just really excited about today's speakers. The first thing I'd like to mention when we're preparing for this, as the speakers, the moderator and the speaker are logging on, if you notice the background, clearly I was the one who was not prepared with the background. They both had these backgrounds and we kind of talked about it for a minute, but you know, the messages on their background are extremely important to what we're going to discuss today. So World Hepatitis Day is on July 28th, but as an organization, POHAIR, we're starting this conversation early. Our moderator for today is Dr. Nkenge Tazikeng, who is a POHAIR scholar. He recently defended his medicine thesis, so we are very excited and proud of him. Congratulations. He is one of our future gastroenterologists, and he's also one of the founding board members for the African Association of Future Gastroenterologists. So I am just excited about the conversation today. And our speaker today is Professor Olufunmilayo Lesi. And I am, we prepared for this in advance. We talked about this. We're actually on the same WhatsApp group, the Society of Gastroenterologists and Hepatologists in Nigeria. And so a few months ago, when I saw what her additional role would be with the WHO, I was just beyond proud and excited for what she is going to continue doing. I'm excited to listen more about her, career, her journey in gastroenterology. She'll probably touch a little bit about gastroenterology within the continent, but we'll focus on hepatitis. So we'll, if you're tuned in the webinar, please feel free to use the Q&A or the chat box. If you're watching us on Facebook or any other form, please feel free to type your questions in. I will now step away and hand the stage over to our moderator, Dr. Tazikeng, and our guest speaker today, Professor Lesi. Thank you so much for your time. Very much appreciated, especially on this weekend. We truly appreciate your presence. Looking forward to this conversation. And it is over to you both.
Okay, thank you very much, Dr. Akwi Asambang, for handing over the stage to us. Thank you, Professor Lesi, for giving us your time today to join us on this call. Personally, I'm very excited to be on this call with you. I must let you know now that I've been your fan. I've watched you present at several conferences, COLDA, No Hep Moms, and it has always been amazing. I remember a few months back, there was the No Hep Mom presentation where we're talking about prevention of mother-to-child transmission, and Dr. Asambang and I, after that, we were discussing, and she was like, yeah, she learned a lot. So that's just to say that we are fans, and I'm very excited to be joining you on this call. So our viewers, welcome to this presentation, and just to remind you that you're currently tuned in into the July session of the Pan-African Organization for Health, Education, and Research Scholars Program. And today we are going to be having a conversation with an expert, a gastroenterologist, Professor Olufunmilayo Lesi. So we are going to talk about her career journey and World Hepatitis Day, which is coming up on the 28th of July, with a focus on Africa. So without wasting much of your time, I'm going to go through Dr. Lesi's biography. So Dr. Olufunmilayo, or Funmi Lesi, currently leads the hepatitis team in the global HIV, hepatitis, and sexually transmitted infection programs at the World Health Organization, and coordinates hepatitis activities in collaboration with other WHO departments to provide technical and strategic support for viral hepatitis elimination efforts in countries. She was previously regional advisor for viral hepatitis at the WHO Regional Office for Africa, and contributed to strengthening national hepatitis responses in over 22 countries in sub-Saharan Africa. with emphasis on adopting a public health approach to hepatitis control and facilitating clinician-public health interaction. Professor Lesi currently provides and coordinates technical support for the development of national strategies and policies related to hepatitis epidemiology, prevention, and management, in addition to proactively contributing to enhancing the regional profile of viral hepatitis. She's Professor of Medicine at the College of Medicine, University of Lagos, Nigeria, an honorary consultant gastroenterologist hepatologist, and head of hepatology at the Lagos University Teaching Hospital, where she coordinated the clinical management of patients with viral hepatitis and advanced liver disease and cancer, and established postgraduate training and development in medicine and hepatology, including the World Gastroenterology Organization Endoscopy Training Center in Lagos. She has been actively involved in hepatitis and liver cancer research in Africa, including the Gambia Hepatitis and Liver Cancer Intervention Study, and has many publications in local and international peer-reviewed journals. She is a member of several national and international groups, including WHO's Scientific and Technical Advisory Group on Viral Hepatitis, the European Association for Study of the Liver, American College of Gastroenterology, and the Society for Gastroenterology and Hepatology in Nigeria, SOGIN. So what a heavy biography we have for Professor Lesi. And Professor Lesi, I will hand over the floor to you. We have just listened to your biography, but why don't you tell us more about you, your person, and what you do on a daily basis?
Right. Thank you very much, Dr. Nkega. And first, I would like to thank OHA for the opportunity to be here. And I am really, really excited about what your organization is doing for mentoring African gastroenterologists. And first, to maybe talk a little bit about World Hepatitis Day, because that is one of the reasons we are having this discussion, which holds in 10 days from now. And like your background shows, the theme, the global theme is Hepatitis Can't Wait. And the essence is to convey the urgency of efforts needed to eliminate viral hepatitis as a public health threat by 2030. Now, the great thing is that this theme is versatile and has been adopted by different regions of the world to reflect their own reality, recognizing that there are over 350 million people with viral hepatitis. Let me put that in context. There are 40 million people with HIV. All right, so there are 350 million people with viral hepatitis, and there are 3,000 people dying every day from the effects of viral hepatitis like liver cirrhosis and liver cancer. So for example, in Africa region, they have adopted the theme Mothers and Babies Can't Wait. And this reflects the need for antenatal testing of mothers and delivery of the hepatitis birth dose for the babies. There are also regions with liver cirrhosis can't wait, reflecting the 26 million undiagnosed liver cirrhosis worldwide. So there's funding for viral hepatitis can't wait. So it's a really catchy thing to show that there are many perspectives to viral hepatitis. So your question is, I should tell you more about myself, right? Okay, so I'm excited to do that. I'm a hepatologist, gastroenterologist with a vast clinical experience in liver disease, liver cancer. And I can say, I think, that I'm one of the early pioneers of gastroenterology in Nigeria. I've been a trainer and a teacher and academician for nearly 2 decades. That's 20 years. I wouldn't ask where you were 20 years ago. And I have developed several generations of medical students and residents in internal medicine and gastroenterology, and also have contributed to developing and administering the training curriculum for specialty training in hepatology and gastroenterology in Nigeria and in the West African sub-region. At the time, I was editor-in-chief of the specialty journal, the Nigerian Journal for Gastroenterology and Hepatology. And I've participated in multiple conferences in Europe and in the US and even in the Asia Pacific. In the past 5 years, though, I have had a paradigm shift, can we put it like that? And I'm very much now in the global health space of viral hepatitis. And for me, this space is a place where my passions and my abilities, my experience in hepatology, in cancer epidemiology, research, business school, project management, leadership, everything comes together in one. It's called a sweet spot, or so somebody told me. It's a great place to be. I've gone from an individual level specialist clinician and researcher to a public health clinician in the Africa region, and now in the global space, focusing on improving hepatology across different regions of the world and different populations. My current work is exciting, and I must tell you that one doesn't travel alone. I have a host of friends, families, mentors, and even total strangers that have supported my being where I am today. So I will stop there because I have a lot to say, but over to you. Thank you so much.
Thank you very much, Dr. Lesi, for that wonderful introduction. And I would just like to say you're bigger than I thought. Like I've always known you to be one of my heroes, but today it's definite. You're bigger than I thought. And you made mention of the fact that where you currently find yourself is your sweet spot. I know we are going to come to that, but before that, you've used some terms, you've mentioned certain words. I would just like you to clarify what does it mean to be a gastroenterologist or a hepatologist? So who is a gastroenterologist?
All right. So when I was training, a gastroenterologist was a clinician who specialized in disease of the liver and the gastrointestinal system, which is really from the mouth all the way to the anus. Okay. But I know that in the current training, they have been divided into hepatology and gastroenterology. Where you are, if you're in the US, there are two parts of the same field. And I must say that when I was even at the Mayo Clinic, there were over 100 gastroenterologists, and each one specialized in a different thing. So there was an expert for the mouth, there was an expert for the stomach, there was an expert for the small intestine. So that field of gastroenterology and hepatology has now been broken down into multiple small specialties. All right, so we have also somebody who deals with liver diseases or viral hepatitis, another person who deals with NASH, that is non-alcoholic fatty liver disease. A different person deals with liver cancer. So the short answer is the gastroenterologist is the specialist in liver and the gastrointestinal tract diseases.
Okay, thank you very much, Dr. Lesi. While going through your biography, there's a word I noticed, which I think is the first time I've come across that word, honorary gastroenterologist. So for most people, I see gastroenterologist. What does it mean to be an honorary gastroenterologist?
You know what? I think that may be region specific.
Okay.
Being an academician for us in this part of the world, my career progression is as lecturer, associate professor, and that is the academic line. But the clinical correlate is a specialist working in the hospital, because as you know, in academia, our laboratory is the hospital. So you can't have two jobs, all right? So for us in academia, we may primarily be with the university. So we become an honorary specialist clinician with the affiliated teaching hospital. I think it is a British kind of legacy in Anglophone speaking Africa. I hope that is clearer.
Yes, very clear. And once again, thank you very much for sparing your time to join us on this call. I promised you that I was going to come back to the sweet spot. Now, how did you find your sweet spot? What directed you to gastroenterology, and how has the journey been?
Well, I must say that it's been an amazing journey. And I think one thing is clear. I selected internal medicine over pediatrics or obstetrics. As a medical student, I was excited by O&G and pediatrics. But at the end of the day, I did not want to do pediatrics because I like my patients, in quote, to tell me what the problem is. I don't like to find out. Just tell me where the pain is, which many children cannot do. And I did not choose the liver. I didn't choose gastroenterology. It was not my first choice. It was trusted upon me as an area of need in my teaching hospital. I wanted to do something sexy or glamorous like cardiology. You know how cardiology is? So I was initially miserable with the hepatology and gastroenterology. But today I would say that it was possibly the best decision of my career. And I have to thank the head of Department of Medicine who pushed me into it. I've never looked back since then. So in 1995, 25 years ago, when my journey began, I'll tell you what the gastro unit was. It was a place for parasynthesis of patients with end-stage liver disease. It was a place where we watched uncontrollably as patients had bleeding and they bled to death because we couldn't do anything. It was a place where we saw terminal liver cancers. And these patients, we could not offer them any support. At that time, 25 years ago, house officers and residents alike avoided the gastro unit like a plague because it was a place where people came to pass the rest of their lives because we were not doing any interventions and we did not have the infrastructure or facility to do that. That is how gastro started at our center. So my fascination for viral hepatitis took place as a resident, and my clinical fellowship and intensive training in hepatology in Canada at the McMaster University in Canada and the Toronto General Hospital. I would never forget my awe and amazement when I saw my first liver transplantation. It was further strengthened by 3 years working as a clinical epidemiologist and liver cancer lead in the Gambia, which is in West Africa. That space lasted for about 3 years, and I was working with the Medical Research Council in Gambia. I've also learned the ultrasound scan of the liver, and that for me has been an amazing experience. And I think it's a European perspective. I have learned this hepatology ultrasound scan in Italy, and it's been an amazing world of visualization and three-dimensional visualization of the liver that has made the liver very, very exciting. And I'll add one last thing that has really inspired my hepatology. It is experiencing the awakening of GI endoscopy by training in Canada, also in Chennai and in Sudan, seeing the anatomy, physiology, and pathology of inside the gut. The thrill has not left me till today. So these opportunities shaped my vision of hepatology, and it ignited a dream in my heart that we can do this as well in Nigeria. And to summarize it, I did not rest until these dreams came to pass over a space of 15 years. By setting up the hepatology unit at the Lagos University Teaching Hospital and the endoscopy training center at the same place. I went through various stages. It was a long journey. It was a victorious journey, a journey of determination. And looking back at the opportunities and challenges, I am reminded of ancient African female warriors, which is what we were 25 years ago. Of course, it was a man's world at that time. There were not many women in gastroenterology. So that has been exciting. And one last thing, and I think we all have to do this. Beyond personal actualization, beyond financial remuneration, it is so important that we ask ourselves, how do we use our talent as service for something greater than ourselves? And when you reach that stage, it is no longer a job, it becomes a passion and a calling and a purpose. And I think it's very important because we are going to be in our career for the next 40 years. We need to be excited about what we're doing. Thank you, and over to you.
Okay, thank you. Thank you very much, Professor Lesi, for this wonderful description of your journey as a gastroenterologist. And I still think if you were to go in details, we'll spend more than 10 hours seated on this screen. So thank you for that wonderful summary. And I must testify, you're a female warrior. It's so difficult to see gastroenterologists, pioneers who are women. And I think you're an inspiration to many. And I can see there are so many ladies who have signed up for this call. So this is an inspiration. I'm just telling you, whatever you can do, whatever you want to do, believe in yourself, you can do it. Professor Lesi, present here today, is a testimony. And I also like to say, I think there's the saying that goes, the best always goes with the best. You made mention of the fact that you had the passion for internal medicine, you didn't want to do gastroenterology and hepatology. All along, I've always known gastroenterology is the best specialty in internal medicine. It's the most diverse, the most interesting, and like the best, as I can say it. And that's why naturally, like nature brought you to the best because you are the best. So I would like to applaud you again for that. And you also made mention that you have learned ultrasound scan of the liver. Now I'm trying to bring it into another context. Dr. Akwi mentioned during the introduction that we have started the African Association for Future Gastroenterologists. And I'm hoping that these skills in ultrasound scan of the liver, will be able to transmit it to us. So hopefully we are going to get you to our Association of Future Gastroenterologists to teach us something about the ultrasound scan of the liver. Now, my next question to you, Professor Lesi, is this: how did you transit from medical school to training in Canada? What were the challenges you faced? How many years? Like, how was the interval? What took you to Canada?
Thank you very much for that question. I must tell you that after 6 years in medical school, reading very hard, not having a life, I don't know if medical school has changed. When I graduated, I was content with never ever reading again. I remember when we did the last exam, I said, I'm not reading, it's finished. Because that was 6 years of watching I was watching our colleagues in other courses having a great educational experience while we in medical school were always working. I know you've been through that.
Yes.
All right. So
definitely.
For me, after medical school, we had to do what was called the National Youth Service Corps. And I think during my house job, the thought of doing residency training became much more appealing, because recognizing that in medical school, you are taught general medicine. You are a general specialist, a master of none. So it was important to identify a subspecialty. And for us, training in internal medicine was about 4 years. And we did professional examinations. We have them called the Part 1, Part 2. We have the postgraduate colleges of Nigeria and the regional West African context. And after internal medicine for 4 years, we go back to do gastroenterology for 4 to 5 years. So we have a major exam. And for that exam, I actually came out tops of my class and got a scholarship to go to Canada. And that made all the difference for me in my journey to gastroenterology. Like I had told you before, 25 years at that time, I explained to you what gastroenterology looked like from an African perspective. So going to Canada made all the difference. It changed everything, and it gave me that vision. of what can be accomplished in Nigeria. It's amazing that trainees of nowadays never saw that gastroenterology of 25 years ago. They have seen the foundations that have been built, and I am happy that they are building on that foundation. So all of this story and the stories of nothing happening, they haven't seen that yet. And you know, at one point I thought I'll ask Akwi to tell us her experience in gastroenterology at the Brown University. This is a place where you have everything compared to in Africa, where we have very, very limited GI, endoscopy, and hepatology. It's also a function of technology, really. Many of the technologies that you may have in the US is slowly coming down to Africa. And the training is much more fragmented in Africa, where we have to take different specialties from different places versus where you have all the training consolidated in a single place. I hope I have responded to your question.
Yes, very well. And thank you very much again. And as I said, if we sit here listening to your history and your journey through gastroenterology, we might not live here today. So I'm coming back again to your soft spot. Hepatitis.
I shouldn't have told you about that then.
But you already did. So I'm sorry. We are going to come back to that. So you mentioned hepatitis, hepatology, liver disease research. That is your soft spot. And to the best of my knowledge, you have prepared something for us from your soft spot. So I don't know, I'll hand over the floor now to you to give us the surprise you have for us.
You maybe need to guide me on what kind of surprise you are looking for.
A presentation on hepatitis.
Okay. You want to learn more about it?
Yes, we want to know about viral hepatitis, and the very first thing we'd like to know, in your presentation, you made in the biography, you made mention that you're currently the head of the global HIV, hepatitis, and STI programs for the WHO. So, could you tell us more? What do you do as the hepatitis, the lead for hepatitis in WHO?
Okay, so I'm not the lead for global HIV, hepatitis, and STI, because that is a team that comprises of the three diseases. So what I lead is the hepatitis part of it. And maybe I'll just give you the background. And that is in 2015, the World Health Assembly endorsed a global strategy for viral hepatitis elimination as a public global health threat. Before then, viral hepatitis is a tertiary center disease where people in teaching hospitals manage viral hepatitis. But in recognition of the magnitude of the problem and the high death rates, the world came together and agreed that maybe, perhaps, the way forward is to manage viral hepatitis the way the world have approached HIV. And I keep referring to HIV because we know what has been done in HIV and how HIV was converted from a specialist disease to a public health disease. And the global hepatitis strategy has called for a paradigm shift in the public health approach on hepatitis care, so that in addition to specialist care, there must be a public health approach to viral hepatitis to prevent the liver cancers and the liver deaths. All right, and that is where the WHO unit comes in to support the countries in adapting and addressing viral hepatitis as a public health threat. As you know, there are many ways to manage viral hepatitis. We can wait until the person develops liver cirrhosis and comes to our clinic, or we can wait till they develop liver cancer and come to our clinic. On the other hand, we can go out to meet them in the field, test them for viral hepatitis, and treat them if necessary. to prevent that progression to liver disease. So most of the work we are doing is approaching viral hepatitis from a public health and equities lens and perspective. In this wise, the world has agreed that maybe we should do 5 things, 5 key interventions to prevent that progression of disease. And these 5 interventions include viral hepatitis vaccination in childhood and the birth dose. It includes blood safety and injection safety. As an African, and as you are too, we have a lot of tribal marks, clarification marks, things we use blades for, all right? So some of those are what will promote the transmission of infection. So we need to control that. And in some climes, it is people who inject drugs are the highest risk for viral hepatitis, especially viral hepatitis C. So part of the package is prevention and harm reduction. But I think most importantly was the effort to reach out, test people, diagnose them, and treat them even before they acquire the liver disease that increases the death rates and the mortalities. And I think in a nutshell, that is what we do. So we support countries to develop policies. We help them shape policies and develop plans to comprehensively address viral hepatitis as a nation, not as a specialist care.
Thank you very much, Dr. Lesi. And one thing which struck me is the aspect of traditional operation and scarification as a mode of transmission of hepatitis. And just to say, we recently conducted a study here in Cameroon, and that was one of our major findings. That is, having a history of traditional operation and scarification was associated with hepatitis B positive serology. So we are hoping that one day this document, this publication is going to reach your table, so you and your team can use to bring up guidelines for elimination of hepatitis in Cameroon and other countries in Africa. So our next question was going to be, how do you see hepatitis in Africa? But I think you've already told us a lot about that. So now I'm going to take you to the response. How do you see Africa's response to hepatitis elimination as compared to other European and Western countries?
Okay, you know, that is a wonderful question, and I think the first thing I want to say, you have mentioned your experience with Cameroon, and according to WHO distribution, there are 6 major regions, and I think we have come to the realization that hepatitis affects different regions differently. And therefore, when you want to manage viral hepatitis in the US, in Africa, in Europe, there are different populations infected. Sometimes it's mostly hepatitis B, as there is in Africa. Sometimes their hepatitis problem is only among a certain population. So we have to apply a differentiated approach to each region based on their challenging problem. In terms of how is the response, again, I always go back to HIV. The HIV response has been phenomenal. Do we agree?
Yes.
It has taken them 40 years to get here. The hepatitis response is 5 years old. All right? So if we look at that perspective, in 5 years, have we made progress? I think the answer is a resounding yes. For sure, we have made progress. But we have targets, and our targets will be elimination by 2030. Are we far from the target? For sure we are. All right? And as you know, in Africa, we have a lot of challenges, infrastructure challenges, political commitment challenges that has possibly made us lag behind the global response. So in answer to your question, maybe there needs to be better engagement and better approach. Again, to answer that question, maybe I would let us look at some countries in Africa that has done a great deal for viral hepatitis. If you look at Egypt, I'm sure you know the success story of Egypt. It screened over 60 million people. Let's look at Rwanda. Is also a country making great strides in viral hepatitis. And what do they have in common? Number one, key success factors. We're looking at government commitment. The government has taken a stand that, yes, we will resolve to address viral hepatitis. Number two, they are funding it. Government is developing programs for hepatitis and is putting its money where its commitment is. Now we're going for universal health care. Many governments are putting viral hepatitis in the package of care for universal health care. And then there are partnerships. I know you know about HIV. We have the PEPFAR providing millions of dollars for HIV. We do not have that type of donor funding support for viral hepatitis. And that is the groundswell that we need to build. And also, occasions like this to talk about advocacy to increase the awareness and the education for viral hepatitis. So perhaps I'll stop right here at this time.
Okay, thank you very much, Professor Lesi. And you made mention of the fact that the countries like Egypt, like Uganda, like Rwanda have been successful because of government engagement. What role do governments have in this hepatitis elimination? And do you also think there's adequate engagement from African countries, from African governments towards hepatitis elimination?
Okay, I like that question, all right? But maybe a little bit of a background about Africa. Africa is a continent of low middle-income countries, for sure. We have less developed infrastructure, that much you know. And we have multiple diseases. It is in Africa that you have HIV, you have a lot of tuberculosis, you have malaria, you have diarrheal diseases. So African governments are grappling with a lot of health issues with little or minimal infrastructure. We're also grappling with a lot of donor funding for these infectious diseases. So yes, government is key. Government is key for public health approach, maybe not for specialist care, but definitely for government for public health approach. Funding, domestic funding. I've actually been in Cameroon, and I don't know if there's any health insurance in Cameroon. No. So in many of our countries, people have to pay out of pocket, and healthcare is not cheap. And therefore, in many parts of Africa, we have native doctors, we have pharmacies, we have a host of alternative care providers that don't charge as much as hospitals. So government is important to provide that type of facility and also to provide what we call an enabling environment for donors to come and provide support. Another example, for a country like Egypt, the first thing they did was government commitment, and they dedicated a small proportion of their national budget to viral hepatitis. Thereafter, they were able to get donor funding or loans to support them. So one thing we need to do in Africa is get commitment by advocacy, all right? By evidence. We need to have evidence to convince our governments that this is an important thing. We need to provide funding for this, and that might open the environment for additional support. And one last thing I've learned being in global hepatitis, the important role of community. As a specialist, maybe I did not focus on community engagement or people living with the disease, but you know that in HIV, people living with HIV made a difference in all their countries. We're hoping to get a groundswell of people living with hepatitis to make a difference to our governments and to promote hepatitis in Africa.
Okay. Very well spoken, Professor Lesi, and thank you again. During this talk, you made mention that advocacy is key. That is advocacy and raising awareness and evidence to the government to engage them in the fight against hepatitis. And if I would draw from that, I would think by advocacy, you mean individuals and organizations maybe focused on hepatitis. So the question I want to ask is, do you work with governments only, or you work with these individual organizations? And how do you work with organizations to help them provide evidence and engage their governments?
Okay, that's a great question. I think primarily we work with governments to improve healthcare in their countries. But we also work with international organizations, and we support governments in working with their local organizations, their local communities, the community of people that have viral hepatitis. And for us in Africa, remember the private sector. The private sector is huge. We cannot leave the private sector behind. And I know that there are lots of people involved in private healthcare, which must be carried along to raise the profile of viral hepatitis. So I think the short answer to what you have said is we work together in collaboration with partners. And the partners are the governments, the partners are the international, regional, local organizations, private healthcare, training institutions, all right, and teamwork to get us ahead, including one of the things that I want to highlight that I have very passionately taken up is fostering public health and specialist collaboration. Being a specialist myself, I found that it was important to carry the specialist along in the journey of the global approach to viral hepatitis, because the specialists have an important role to play in setting guidelines and guidance, in teaching, all right, in teaching the population and the healthcare workers about viral hepatitis and liver disease. So it should be a journey between public health and liver specialists and GI specialists in the agenda towards elimination by 2030.
Okay, thank you. And just to say, what you're doing, I know very well that it's difficult to bring together clinician and the public health approach, because nowadays in Africa, most of the times clinicians are focused in the hospital, and we have mostly the public health specialists who are not knowledgeable on this disease going around in the population. And so I know it's difficult, but I really appreciate you for that. And I think you're setting an example to us all to also involve ourselves in community education in the public health aspect of our specialties. It's not only hepatitis, there's HIV, and there are so many communicable diseases. So thank you very much for serving as an example to us all. The next question I want to ask is, one of the strategies in eliminating hepatitis is vaccination, ensuring everyone is vaccinated, and WHO has the criteria for that. They have recommendations for vaccination. Now, we know that 90 to 95% of adults who get infected with hepatitis won't progress to chronic hepatitis. So what is the role of vaccination among adults towards the elimination of hepatitis?
You know what? I thank you very much for that question. And I am glad you asked it, because in the past couple of years, when we do viral hepatitis, I've seen so many civil society organizations go out. They test large populations, then they immunize those who are negative, and generally they don't do anything to those who are positive. All right. Meanwhile, it's those who are positive that are at risk of liver disease. I think the best way for me to describe this is to share with you the modeling that was done by some of our colleagues at a foundation called CDA Foundation. You know what modeling is? They did a mathematical modeling to see the benefits of adult vaccination versus childhood vaccination. Now, WHO recommends childhood vaccination and birth dose hepatitis B vaccination. That's number one. WHO recommends adult vaccination in a certain population of either healthcare workers or people who are at risk of rapid development of liver cancer, or contacts, family contacts of people who are hepatitis B positive. So in this modeling, this group showed that the adult, when you generally vaccinate adults, in that modeling, it prevented over 10,000 new infections. All right? That is a huge benefit. The modeling now showed that if you vaccinate only children or newborns, that program will prevent 15,000 new infections. All right? So it looks quite the same. Adult vaccination prevents 10,000 new infections by 2030 in a particular country and prevents 15,000 new infections in children. They sound similar. But it went on to show that in the adult vaccination program, only 650 of them developed chronic infection or liver disease in the first instance. All right? So adult vaccination is useful. I'm not saying it's useless. But in the childhood vaccination program, it prevented 13,000 chronic infections and diseases. So what we are saying is the adult infection prevents 600 chronic infections, and the childhood vaccination prevents 13,000 new chronic infections. So I'm going to throw it back at you, Nkega. If you have limited funding, who will you vaccinate? Where is the banks? Where is the value for money? Where is the cost effectiveness? So do you want to spend X million to prevent 600 new chronic infections? You will spend the same amount to prevent 13,000 new chronic infections. And I think that is the evidence before us. And that is something we all need to understand, that vaccination is effective and important for adults, but it is, how many more times? 650 versus 13,000. It is a lot more effective, much more. There's no comparison in adults, in children, in vaccinating children than in adults, especially in endemic areas. So we cannot take what is routinely done in the USA, which is a non-endemic area, and cut and paste in Africa. It doesn't work like that because the context is different. And I think this is an argument I can go on and on and on about, but I hope that the evidence I have alluded to is convincing that in Africa, the first step should be vaccination of children and newborn.
Thank you very much. Yes, and that's really wonderful evidence. And I think it's going to shape, personally, it's going to shape my career, because as I said, I'm so excited joining you on this call because we share the same interest: viral hepatitis, gastroenterology, GI infection. So I've really learned a lot, and I hope our audience is also learning a lot. And now coming to the childhood vaccination. As I said earlier, I attended one of the conferences, the No Hep Moms, where you gave a presentation on preventing mother-to-child transmission. And one of the problems raised about mother-to-child transmission of hepatitis in Africa is the birth dose vaccination. We know so many African countries have incorporated hepatitis in their expanded program of immunization. The majority of these vaccinations start at 6 weeks, hepatitis vaccination 6 weeks. And there are so many children who get infected before 6 weeks, before they get their first dose of hepatitis vaccine. So how is Africa dealing with this push towards universal hepatitis B vaccination at birth? And what are some of the advances and challenges faced with respect to implementing this birth dose of hepatitis B vaccination?
Right, thank you again for this question. And like we have agreed, Children who are infected go on to develop liver disease as adults. So that's a fact. And I think one thing we need to do is more awareness and more education, especially for those in public health. All right. One of the major challenges in many parts of Africa, there's an organization called Gavi that provides vaccination for many countries. This organization is not providing birth dose. And in the past few years, they have planned to provide birth dose to support countries. But I think the COVID happened and their plan had to be shelved. As we stand today, about 15 countries out of the 47 countries in Africa, sub-Saharan Africa, have hepatitis B birth dose, including some major countries. But part of the challenges is that the EPI team, that's the immunization team, may be the one to collaborate with the maternal and child health care for birth dose. Birth dose means you give the vaccination within 24 hours of birth. In many of our African facilities, the labor room is nowhere near the immunization place. In some cases, you need to go home. You discharge your patient home and they come back next week for vaccination. That is a logistic challenge we need to address and improve collaboration between the immunization team and the maternal and child health team. Another challenge in Africa, as you know, nearly half our women have birth at home. So we have an issue of how do we reach the population in their homes and administer birth dose. And there are various options and innovations that can be taken to scale to address that issue. But I think one important thing is political commitment. We need to get governments and healthcare workers to see the benefits of birth dose in preventing liver cancer. You know, the world is going on and on about HPV vaccination and cervical cancer. Oftentimes, hepatitis vaccination is not linked to liver cancer. So people are not actually seeing that lack of vaccination can cause liver cancer in the adult population. And I think I'm going to stop right there. Of course, we need a lot more evidence coming out from Africa, proving this point.
Okay, thank you very much. And just to add, during my years of during my clinical rotations, one thing I noticed is another thing in addition to what you have said is the fact that most of the times birth dose vaccination is given only for children born to mothers living with hepatitis B. So that is, if the mother is hepatitis B infected, that's the only instance where we are like conscious that we have to vaccinate these children for hepatitis B at birth. And I think what you have said is really a call. It's a call to us, to the government, and to everybody to incorporate birth dose to every child born in Africa.
But just to build a bit of what you have said, you're correct. But the point is there is no system in many parts of Africa to systematically test the pregnant woman in the first instance to know whether they are positive or not. And what we are advocating now is what we call triple elimination. Systematic testing is being sponsored and done for HIV testing and syphilis testing in many parts of the world, in many parts of Africa. And what we're advocating for is that they should include hepatitis B in that package for pregnant women, that all pregnant women are tested, all right? And if positive, in addition to universal birth dose, some of them need prophylaxis with tenofovir to further prevent mother-to-child transmission. So
Okay.
that is a big message for us.
Okay, thank you very much. I know we're getting closer to the 1 hour mark, but there's this question which I really want to ask you. Given that we know that hepatitis mortality in Africa is rapidly on the rise, and it's WHO data shows that hepatitis-related mortality is higher than mortality due to HIV, malaria, and TB combined. So we have seen so many governments are trying to ensure that HIV treatment is provided at a free cost. do you think we should also be fighting for free treatment for hepatitis B in Africa?
All right. Again, I have to thank you for that question. I'm going to refine the accuracy of your question.
Okay.
So what WHO has shown in 2015 is a rising death rate of viral hepatitis compared with a declining death rate of HIV. And modeling studies show that if nothing is done, the death rate will exceed the combination by the year 2040. Not today, but in 2040, if nothing is done. But much is being done.
Okay.
All right? And I always say that the journey of 1,000 steps begins, of 1,000 miles begin with one step. So a lot is being done, a lot more needs to be done. And yes, we do believe that viral hepatitis should be managed free of charge, especially at the level of primary health care, at the health centers, all right? At the community level. And what is being done for HIV can be done for hepatitis. But you know, there comes a point where how many vertical diseases can you have? You have a TB clinic, you have HIV clinic. Do you now also want hepatitis clinic? Then you have hypertension clinic at primary health care level. So going forward, we're looking at, is it possible to integrate these things, these diseases, and use the available facilities at the primary health care level for both HIV, TB, hepatitis, hypertension, diabetes. So we're looking at integrating. Look at the laboratory infrastructure for HIV. The COVID pandemic is building on the HIV foundation. Why can't we put diseases into this foundation? Because those laboratory machines they do what you ask them to do. The same lab tests, the same machines will work for HIV, hepatitis, and many other diseases. So maybe going forward, we should think of how can we be strategic and combine all of these things at the primary healthcare level, maybe secondary, maybe not in tertiary care because they are specialized. So I think the answer is yes. We need to think differently of how to get hepatitis as a public health disease addressed. So major obstacles. One is funding. All right. Yes. Where's the global fund for hepatitis? Where's the PEPFAR for viral hepatitis? Government commitment. All right. All of those things are important. Stakeholders, community engagement. You know, for me, when you talk about community engagement, I better understood that word in the context of COVID. For COVID, the community, they were told to wear face masks. Did they wear it? No. So the community is a very, very important part of the COVID success stories. They were told to stay at home. They were told to face mask, wash your hands, and all of that. That is the contribution of the community to disease elimination. So we need awareness of the community to viral hepatitis, and that can only be done by education and political commitment going forward.
Okay, so thank you.
COVID is a wonderful example of what should be.
Thank you, Dr. Lesi. And talking about COVID, I think COVID was used as one of the references in choosing this year's theme for World Hepatitis Day, because we see the focus, everyone is focusing on COVID, and the efforts made towards hepatitis elimination, we are like on our run towards hepatitis elimination, we are going backwards because everything that has been put in place is being tampered with by COVID. So I think that's one of the reasons why we also choose hepatitis can't wait, as in the context of COVID, we still need to fight towards hepatitis elimination. So now, as an expert, given that most of the community campaigns, awareness campaigns done towards geared towards hepatitis elimination, most of them are no longer possible. There is so much funds in which is redirected to production of COVID vaccination and managing patients with COVID. What do you think could be the way out, an easier way out for hepatitis elimination in this context of COVID?
All right, I like that question because COVID is redefining and reshaping future of everything, including healthcare.
Yes.
So what are we going to have in a post-COVID era? People are talking about build back better. You've heard that term. They're talking about build forward better. And they're talking about what can we learn from the COVID response to apply to other diseases, including hepatitis, including hypertension and diabetes. Of course, you cannot compare anything to COVID. COVID is a pandemic that is sweeping around the world, but there's something to learn from it. And I think one of the very important things we're learning about COVID is integration and primary health care. If you don't have a solid health infrastructure, you cannot address diseases. We're talking something called person-centered care. You know what that is? The person with COVID has hypertension and diabetes, and that same person has hepatitis. Will you treat him of the COVID and leave the rest? Then he will die of the rest. All right? So we're looking at, if you are thinking of promoting a person-centered care versus disease-centered care, then you need to strengthen your primary health care, where the primary health care level can deal with me as a person and manage my COVID and my hepatitis and my hypertension. So we're looking towards primary health care, integration, and for many of us in Africa, one thing it means for us is universal health coverage. If our governments were to ask everybody to pay for the vaccine for COVID, guess what? Only the rich minority will afford the payment. So there's something we need to do for the majority of our populations who don't have funding. So government commitment to building healthcare is integral to making progress in healthcare and in hepatitis. Another thing that is being perfected in COVID, every day you hear the numbers of, 20 cases today, 500 died. How did they get that information? Because they are monitoring it. Perhaps they should monitor diseases like that. And if we really knew how many people died in Africa per day, then we have data. We're powerful. And that data can be used to make a change in our communities. And I will stop there. But there's a lot more to talk about.
Okay. As you said, there's really a lot more to talk about. And before going into the other types of hepatitis, because it's true in Africa, whenever we talk of hepatitis, most of the times we think it's viral hepatitis. But we are aware that there are other kinds of hepatitis and they are becoming a problem in Africa too. So we are going to go towards that direction in a few minutes. But before then, there is this problem which so many people living with hepatitis B encounter. There is the question they always ask: when are we going to get a cure for hepatitis B? And for others who are not infected with hepatitis C, we keep asking ourselves, when are we going to get a vaccine for hepatitis C? So from a global perspective, what do you think is the current state of research towards finding a cure for hepatitis B and a vaccine for hepatitis C? Where are we at this moment?
You know, I like your question, all right? And it's amazing how a vaccine for COVID came out really quickly. Maybe we need to move the world to pay that type of attention and put that kind of money in HCV vaccines. And while they are doing it, they might as well just do HIV vaccines as well.
Yes.
I think there's a lot of research to be done. And one thing that is available for hepatitis B is the vaccine is available. All right. So my question is, why are we not optimizing the available vaccine in the first instance? All right. If they make a hepatitis C vaccine or HIV vaccine, well, maybe Africa will be the last place where this vaccine arrives. But yes, you're right. I think going forward, innovation is needful. Additional research is needful for getting a hepatitis B cure and hepatitis C vaccine. And I think you are the gastroenterologists and researchers of the future. So I shall ask you that question in another 50, maybe 10 years. And hopefully you will be part of that movement to eliminate viral hepatitis by the year 2030. Thank you, Anu.
Thank you very much, Professor Lesi. So we are now going to move over to the other types of hepatitis. And we have always been hearing of non-alcoholic steatohepatitis, non-alcoholic fatty liver disease, and they are always put together. I think on the 10th of June was the World NASH Day, and I was opportune to attend the online symposium by the Global Liver Institute. And they brought out this problem. I was also so happy to see that so many African countries are currently joining the task force to eliminate NASH in Africa because it's a rising problem in Africa. I would like to know, what do you think how much of a problem is NASH in Africa? But before then, what is the difference between NASH and non-alcoholic fatty liver disease?
Okay. I'm going to put it like this, like non-alcoholic fatty liver disease is a spectrum disease. It has, the bottom line is lipid or fat accumulation in the liver. And one of the things that I understood earlier about NASH is that we always thought that fat was inert. Now we know that fat is alive. Fat causes inflammation, and NASH is activated fat that is causing steatohepatitis and inflammation. Now, I think the challenge with non-alcoholic fatty liver disease is that it is a metabolic component of the metabolic syndrome, and it is very rarely acknowledged as a primary disease. It is a disease that accompanies obesity, diabetes, hypertension, dyslipidemia. All right. So in the definition of metabolic diseases, you know what? They sort of underestimated the effect of steatosis and accumulation of fats in the liver. So it's a global shift that we're seeing now in the wake of diabetes, in the wake of impaired glucose tolerance. And it's not an African problem. It's a global problem. It's a globally underestimated problem. In fact, some people are thinking we should call it metabolic associated fatty liver disease. So there's a group that is really routing for calling it MAFLD rather than NAFLD. So there's a lot of work to be done, and we have been involved in some research of fatty liver disease. Limited data from Africa suggests that 10 to 14% of the population have what we call NASH. But again, remember that most of the deaths caused by NASH are not liver disease. The deaths will be due to cardiovascular disease, hypertension, heart attacks and strokes. All right, so maybe I'll put it like this. NASH is a complex disorder secondary to many metabolic diseases, and we need to highlight it a bit more. We need to improve and increase the awareness and maybe define guidelines to how do we begin to manage NASH and what is the size of the problem. All right, so there's really no reporting of NASH in many major hospitals or government surveillance system. So there's a lot of research and surveillance needed. And of course, we are talking about sugar sweetened beverages, processed food, and all of those complicated things that accompany non-communicable diseases. So it's an entire chapter on NASH.
Okay.
But I'll stop
Right
right here.
Okay, thank you again, Dr. Lesi. Now I'm going to get into alcohol. You mentioned that there are so many deaths from viral hepatitis B and C in Africa. And we also know that we are facing this problem of alcohol consumption in Africa. Do you think alcohol consumption has a relation to the mortality due to viral hepatitis B and C? And how is that addressed?
You're asking complicated questions in a short time. But the short answer is for sure. Maybe two things. Alcohol is an independent risk factor for liver disease and all-cause mortality. Alcohol affects the brain, it affects the heart, it affects everything. So by itself, it is a major risk factor. Then there's another concept of synergy. It works with hepatitis B and C to compound the liver effect of those diseases. And one thing I like to tell my students is, 1 + 1 = 2. That is addition. But when 1 + 1 = 9, that is synergy. So what alcohol does to viral hepatitis is works with viral hepatitis in a synergistic manner to enhance the progression to liver disease. So the answer is yes. So we need to address alcohol as well. That's a very important risk factor. And there are many studies and evidence that have shown that this is the truth and this is a fact.
Okay, thank you very much, Dr. Lesi. I think we should be rounding up now. But before we round up, I would like to know what are the most common complications of hepatitis globally, be it alcohol, NASH, viral hepatitis. What are the most common complications and how much of a problem?
You know what? We cannot take it like that. Let's break it down.
Okay.
So I'm going to talk only about viral hepatitis.
Okay.
And you have viral hepatitis A, B, C, D, E. All right? We know viral hepatitis A and E. They cause gastroenteritis, they cause jaundice, they cause they are waterborne. They contaminate our food and our drink. They occur in areas of poor development where there's no running water. They occur in places where feces is not processed or thrown away. All right? So in some countries, there's an epidemic of acute viral hepatitis caused by these waterborne diseases. So the response to that is maybe to improve the living and socioeconomic conditions, all right, that provide that environment for hepatitis A and E to thrive. And of course, you know that in pregnant women, hepatitis E causes liver failure. The second is hepatitis B and C, separate from acute viral hepatitis. And we do know that these lead to liver cirrhosis and liver cancer in the proportion of people who have these chronic infections. And therefore, the care and prevention of B and C differs from hepatitis A and E. And except you want something particular, maybe you want to ask what it is. Hepatitis B, we know, can be prevented with childhood vaccination and vaccination of people at risk for the disease, including all healthcare workers, which we know is not being done. All right? So it's different from alcoholic hepatitis, that is alcohol. It's different from drug-induced hepatitis, that is drugs. And they all have different prevention strategies depending on the cause.
Okay. All right, thank you very much. I think you answered the question, and I guess our viewers are happy with that response. So we are getting to our final questions, and one of our final questions is, what role do you play in GI training in Africa? Because we know GI diseases are on the rise in Africa, and we need more specialists. We need more of us getting into gastroenterology. And thank you for challenging me to answer a certain question in 10 years' time on the elimination of viral hepatitis. I think we need more persons getting into gastroenterology. So, what role do you play in training future gastroenterologists in Africa? And how do you see the future of gastroenterology in Africa?
Um, I think it's a very important question. And in the past 25 years, I must say that the field of gastroenterology has tripled in many parts of Africa. I've been to multiple countries, over 22 countries in this region, and we're seeing gastroenterologists and training coming up. For myself, in terms of training, I think I've spent over a decade in training and manpower development in medicine, in gastroenterology at undergraduate level and at postgraduate level, and also as the training director at the WGO Endoscopy Center. What is really exciting now is the power of Project ECHO. I don't know if you've heard about Project ECHO. Project ECHO is an innovative tele-mentoring using a hub and spoke knowledge sharing approach. And I think it is a technology that has come of time. It was just at the right time because COVID has made all of us more virtually aware. This technology is popularized by the University of New Mexico, and it is an important tool now to reaching gastroenterologists that may not have access to high technology that is available in other countries. It's also a way for us to teach some of the healthcare workers or the GPs the basic management of viral hepatitis B and C so that they can provide this care at their center to patients that may not be able to come to the teaching hospital to see a specialist gastroenterologist. So there are lots of things happening in the learning space. And I must say that the sky is the limit with technology and with learning. And it's been fantastic, really, mentoring junior gastroenterologists in Nigeria. And I see many of my colleagues here from the Society for Gastroenterology and Hepatology in Nigeria. And that is a platform that brings us all together and helps us to speak the same language. So I would stop there and say thank you and over.
Okay, thank you very much, Dr. Lesi. And I also like to thank Dr. Asombang for responding to the questions in the chat box. I think it's going to save us time. So now,
can I address a question? Hello?
Yes, go ahead.
All right.
Yes,
and I want to address, I saw a question in the chat talking about immunoglobulin.
Yes.
And let me tell you the story about immunoglobulins. When I was in Nigeria, in Lagos, I would see my house officers writing immunoglobulin for a woman who is wearing rubber slippers. All right. So here is immunoglobulin costing maybe $100. And this woman earns less than $1 per day. How do you marry the two of them? Does she really need immunoglobulin? All right. So I think immunoglobulin is an important tool, especially for high-income countries, and especially for the Asia Pacific, where there's a lot of hepatitis B, E antigen, and high viral load. One of the recommendations of WHO now is universal birth dose. All right. So immunoglobulin is not a primary recommendation, especially as the science has shown that many women in Africa with hepatitis B surface antigen may have a low viral load and may not require immunoglobulin. In many developed countries where patients have hepatitis B, they do a viral load. And women that have a high viral load or that are E antigen positive are really the types of people that immunoglobulin is administered to. So I just want to, on this platform, say that immunoglobulin should not be a reflex right for patients who are earning less than $1 a day and do not have the money to procure immunoglobulin. Which brings us to the issue of universal birth dose, the issue of maternal prophylaxis, because the latest WHO recommendation of a year ago suggests that if a woman is surface antigen positive and has a high viral load, give her tenofovir in pregnancy to reduce the viral load and reduce mother-to-child transmission. I think I would stop there. So the message is that maybe we don't need to give immunoglobulin to everybody. Maybe it should not be a routine prescription. What is the added value of immunoglobulin in our patients that earn less than $1 per day? Those are all things we need to think about before giving immunoglobulin. And one of your questions was research. We need to do a lot of research in Africa to see what if we don't give immunoglobulin? How much transmission is ongoing? Do African women really need immunoglobulin? What proportion of them would need immunoglobulin? And I think this, for me, is cause for research, because the research we are using is the research that has been based in China, where they have a lot of viremia in their young pregnant women. We need to have an African cohort and make decisions based on our own situation. And I think I'll stop there. Thank you very much.
Thank you very much, Professor Lesi, for your time and for this very informative session. I think we are at the end of this session, but before I hand over to Dr. Asomban, do you have any final words for us? What's your summary, or what take-home message do you want to give us at the end of this session?
Sorry, that for me, right? So
yes.
For me, okay. Dr. Akwi, please, over to you.
I think it's for you.
Okay.
That's the question for you. Yes, ma'am.
Okay. Well, the question for me, I think we need a lot more people interested in hepatology and gastroenterology. It's a fabulous field, and I want to encourage younger people to go for this field. It's an amazingly rewarding field, and it's a growing area, especially in Africa. Number two, I think one key message, and I saw something like that in the chat, is about triple elimination for hepatitis B in Africa, which means testing the mother for HIV, for syphilis, for hepatitis B at the same time, at the same pregnancy, so that we can address the three of them at the same time. Number three, for young people, I think they need to find their passion, something they are passionate about, and use it as a service, and thinking of the impact to the population, impact beyond them. And that will serve everybody well into their future. And of course, we need more people in global health. We need more Africans in the global health of viral hepatitis and different diseases. All right, we need to be interested in that. And I think on that note, I want to say thank you very much. It's been an amazing opportunity to tell my story in my way, an African story. And I think it is something we can all work together, to improve the progress of healthcare in Africa. Thank you, and over to you. Akwi, thank you so much. It's been a wonderful session.
Thank you. Yeah, thank you so much. I don't even know where to start, but on behalf of the Pan-African Organization for Health Education and Research, we are absolutely thrilled that you could take the time out of your busy schedule to be here with us. And this is really an important topic, the topic of hepatitis. B, and hepatitis in general. And I like your emphasis when you talked about the impact of vaccination. I liked how you were able to differentiate, the birth dose in an adult. And, for my personal story would be, I actually had my vaccination as an adult. So I actually had it in medical school. So once I became more aware of this, we had it at time 0, 1 month later, and then 6 months later. And so this was as an adult. That's when I had my my vaccination. And granted, it was about 20 years ago. So they check my titers now. As part of employment, you need to be vaccinated, and my titers are still good. So it was it's a very it's a good, strong vaccination, and it's good, as you mentioned, when you think of the complications associated with hepatitis, hepatitis B specifically, or hepatitis C. Prevention is better than cure, as they say. And so, this has really been informative. Even though World Hepatitis Day is on July 28th, we don't need to wait until July 28th to start talking about this this important message. And Dr. Tanzan Kang has done a fantastic job. I mean, like you said, I know beforehand we talked. We have to try and limit it, but there's just so much to talk about. And we'll definitely I know you and I are going to be talking behind the scenes, because we've got a lot of collaborations to do between you, me, and Dr. Oyeleki, Ganiat Oyeleki. Yeah, so we'll be talking behind the scenes, I know, but this was a really, really important topic, and I can't say thank you enough on behalf of the whole team on a personal note, and truly appreciate your time. And on that note, yeah, it has been about an hour and a half. So,
yeah.
So we should wrap this up. I will call this to a close, and to all those in the webinar, to all those on Facebook, good morning, good afternoon, good evening. Have a fantastic day. Feel free to send us any emails, any notes. If you have any questions, we'll definitely try and bring Professor Lesi back, whether it's through POHER or through the AFG. She's definitely going to be, or is, one of the mentors, female warrior, as we say. So thank you so much. And everyone, have a fantastic day. And till we meet again, take good care of yourselves. Ciao, ciao.
Thank you so much. It was great to be on the show. Thank you. Bye.
Thank you. Take care.